I'll start here, then move there. I'm sorry.
No circus questions, please. Okay?
Thank you. My name is Alice from GS1 Sweden, and we've been trying to get some activities going in Sweden, and it's actually been very difficult. And one of the reasons it's been difficult is because all the regions control themselves. So we do not have any central steering. So we have the regions where you have politicians that actually allocate the money that goes into the regional hospitals. And then you have a challenge because we are trying to show them the connection between supply chain and clinical processes and completely failing. So I'm just wondering, how did you actually get people to see the connection between what you do with the product with what happens to the patient?
Very interesting question. If you make traceability of surgical instruments, like showed presented Frederic, it's very simple to show to your CEO or to the administration the effect of standard, for example. It's very easy, in fact. You have the traceability. You can show that, okay, I have the information during all the process of the surgical instrument, and I increase patient safety. This is for one example. And for drugs, it's the same thing. You can, if you make the chemotherapy, you go to your CEO or the ministry, you show them, look, here we have made the traceability of all drugs we administer to a patient. That's for example. Okay.
I think that the challenge we are having is that the people who hold the money say that those things have to do with the supply chain and logistics and have nothing to do with the clinical process. So we are having some kind of difficulties getting them to connect that. And I'm surprised because it seems like everybody else in all the other countries actually make the connection, but there's something for us that's lacking there which we need to identify.
Eric, could you comment on that, because you had to convince the strategy group within a hospital to release money, I assume, for your project too. So did you find it hard to persuade your colleagues to do that?
Well, fortunately enough, the CEO was a former physician as well. And we could present for him this business case with a return on investment within 1 year. Along the way, when we started to implement and we started our journey through the hospital, we started with the quick wins, and for the operating rooms, in our case, that was the orthopedic surgery. And we had to talk with the orthopedic surgeons about that. And, well, sometimes it takes a lot of words to convince people, and sometimes people see the profits and the benefits. And for the medical doctors, the most profit could be found when they had to do a recall. And we had a recall last year about knee prosthesis. And when we were still living in the Stone Age, it took about 3 weeks to go through all the paperwork and try to identify all the patients that were involved with that kind of prosthesis. And it took a lot of paperwork to find the prosthesis in the stock department. But in the most recent recall we had, we knew exactly within a few hours or minutes or a few mouse clicks away where the wrong or where the recall prostheses were. They were still in stock. They were not implemented yet in patients. So we could show to the orthopedic surgeons that this was so convenient, this system, and that also helped in building trust for the orthopedic surgeons, and they can help us spread the word throughout the hospital, if that is answer to your question.
Hello from here. I'm a hospital pharmacist in Athens, Greece, and I personally have to thank George Nicholas for his presentation, because if it took 10 years in France, then us in Greece should not despair. We can have some results in the future. I actually want to ask Eric, what happens if you have the right place and you have the right time, but you don't have the right people?
Then it won't work.
Okay.
You really have to have the right people. And I cannot point at those people, that's the right one. They have to pop up themselves, I guess.
It's usually not top-down, but down to top sometimes in some environments or countries. So you try to persuade those that take the decisions that it is evident and it is evidence-based and then it should be implemented, but it is never implemented because you don't have the power in your hands to do that. Should you despair or should you go on trying to find the right people getting to the right posts?
Don't hesitate, just do it.
Yeah, but and I agree. Just do it. But sometimes, and I don't mean this flippantly, you need a good crisis. So in our case, we had haemophilia patients infected with HIV and hepatitis. Suddenly, money was available. Valerie's case was CJD. Suddenly, money is available. We have another system, our track and trace of surgical instruments, because somebody left something in a patient. And so sometimes, unfortunately, healthcare is very reactive rather than proactive. So when there is or even the heparin, there was heparin contamination, or the over-heparinization, but there was also heparin contamination in the US, where a contaminated batch went back to a warehouse and then went back out to the hospital again and was given to patients. So unfortunately, healthcare, we're not as proactive as they would be in industry, where they would have a strategic thinking, or even private hospitals. Public hospitals just tend to react to crisis. Hi.
I was very impressed by all the presentations from France and from the Netherlands about implementation of scanning that an implant or whatever device is used for a patient. What I didn't hear addressed is whether this documentation comes on top of the clinical documentation. Like in a patient record, you would document that this and that hip has been used, or in an operation report by the orthopedic surgeon, he would want to mention which device was used. And none of the speakers said whether this was integrated with the scanning, or whether that was a totally different process, more geared towards regulatory or material management affairs. So we're right now in a very similar project, and we actually started out with the precondition that these processes, these work processes for the people in the OR, have to be integrated. And this precondition actually kept us up 2 years because we didn't have the proper software integration. And once we had that, it was very it was a very big effort and quite painful to get that degree of integration. And IT integration also cost a lot of money, like a 5 to 6 digit euro amount. Now we have it. Now we have an integrated process, and we are going to start rolling it out. Just asking the people that have implemented it, have you implemented it to be an integrated workflow, including software integration, or what is your experience with that?
I completely agree with you, but we are very dependent on the IT system and the interaction between the IT system. For example, something I didn't speak of, we are doing the scanning at unit level, because they are delivered like that, of all contrast products for imaging. And it was perfectly easy. Our radio information system, they just told us, yes, you want to scan the picture. I didn't even know about data matrix, but you want to scan the picture. Yes, you just put the scanner and you scan. And we did put the scanner, we scan. You know, we have the article list with the numbers, of course. And you just go into it, you know, just scan, inject it. They know the if they put the full dose, or you know how much they did put. It when the le compte rendu, no, when the report, you know, when the radiologist writes its report, dictates his report, the number will be imported directly into the report, because it's a mandatory traceability, and in our system, the image and the reports are going. The report is going to the in the patient record. It is in the documents. It goes, and of course, the image can be accessed directly from the PACS into the image. So it's a direct link to. I can't say it's so easy with other, because we can make a link with the pharmaceutical system, but we don't have the perfect link between the pharma system and the information record. But we are trying, but it costs a lot of money. It must be asked by other hospitals, because, you know, it's something which is used, what the ex-Mackison we are using. So it's always the problem of trying to go a bit forward without, you know, waiting 2 years to do something and having the product. So for some we have, for some we are still, but we still keep it in our minds. We always ask that it be included, because the financial problem are one thing, but what we want is to have it into the patient electronic record. I do completely agree with you.
Okay, I think we're very pushed for time, so we have two. Sorry, Hayo, but we have two quick questions. Yeah.
Hi, it's Edward Glenn from the GMDN. I was just wondering how you integrated adverse event reporting within this system. Is it done completely separately, or part of the patient record? Is it linked to the patient record in some way? I'm just interested how you did that.
Yeah, please. I think so on.
Well, to answer also the other question, the Netherlands built a web-based application, and there comes all the things together. Because the solution providers don't adopt these one standards yet in our hospital, so we combine them in a web-based application with interfaces. So all comes together in kind of cloud technology.
So you're scanning in, and it's populating a web-based application.
Yeah, with interfaces.
Okay.
Hello, panel. I wonder, could you help me? We supply the medical device with products, and I was just wondering, what's the story with the medical device people when they have to go to get them sterilized? Some of them have E-beam, and the other have the other product. not the sterilized, not the sterilized, the gas one, the steam one. Is there a problem when they go to get them cleaned at the end?
So is there a problem with the barcode coming off, or
No, when they go to get it at the end. Because I know one of my customers has to go to England to get them cleaned out. The others just go into the theatre.
I didn't catch that, Tanya. Did you?
One of them has to go to England to get them.
To get cleaned.
Yeah.
Okay.
And the other just goes into CSSD.
So if you're sending something away for cleaning,
That's right, yeah.
and what's
Others
the?
just let it done locally. Because I live in here and they say, some of the sterilisation units only have steam unit.
Was your question with the barcodes on the
No,
products?
it's nothing to do with the barcodes. It's just with the, if you send your product to a company and they go along and they only have a steam, and then another theatre only has an E-beam. So is it okay in a hospital to take E-beam if they haven't a sterilisation unit for it?
It's just the type of sterilization. Yeah. What? You want to speak about it later? Yeah, if you contact, I think Valerie may have an answer. Sorry, no, not Valerie. Sorry, Frederic may have an answer for you. So if you contact Frederic after the presentation. Oh, okay. So we're out of time, but I'd like you to show your appreciation for all the speakers today. So thanks very much. Thank you.